Hello, everybody. This is Dr. Kurt Woeller from Integrative Medicine Academy. I want to welcome you to this webinar. We're going to talk about small intestinal bacterial overgrowth, also called SIBO. And one of the reasons that testing is important, but particularly a certain type of testing called mycotoxin testing, which are toxins produced from mold. So I'm going to talk about that. We'll talk about SIBO in general, and then we'll get into the mold topic a little bit. Just as an overview for this topic, you know, it's important because SIBO is an issue that affects, you know, thousands, if not hundreds of thousands of people, and then, you know, certainly around the, not only here in the United States, but around the world. So it's a real problem. And us as integrative and functional medicine, you know, practitioners need to have a working knowledge about how to address SIBO problems, because it's more than just a problem of bacterial overgrowth in the small intestine. There can be many things that lead to the development of SIBO. So I'm Dr. Kurt Woeller. I have been an integrative and functional medicine physician for over 20 years, about 23 years to be exact. I've done a tremendous amount of clinical education in my career. I do clinical education for Great Plains Laboratory regarding their organic acids test. I've spoken throughout the United States as well as internationally on various topics related to functional and integrative medicine. I'm the co-founder of Integrative Medicine Academy, which is an online training academy with online courses in various topics related to integrative and functional medicine. I'll talk about that a little bit later. And I'm also the medical director of something called Functional Medicine Clinical Rounds, which is a new website we have that is for healthcare practitioners who are wanting one-on-one assistance, lab interpretation, clinical troubleshooting, case analysis, these types of things. And I've worked with patients with SIBO, with gastrointestinal problems, other autoimmune conditions, as well as autism and neurological disorders. So SIBO and irritable bowel, there's often an overlap. So SIBO is a condition where we get increased numbers of normal intestinal bacteria, many of these colonic bacteria that find their way into the small bowel where they normally shouldn't be, at least in large numbers. And SIBO can actually be associated with irritable bowel being linked more commonly to problems in the large intestine. Approximately 45 million Americans suffer from irritable bowel, they figure about 30 million or so going undiagnosed. And irritable bowel is the most prevalent GI disorder in the entire world. So approximately 80% of irritable bowel patients also have SIBO. And one of the things to keep in mind is the reason that these things can sometimes be separated out or sometimes overlap is because of compartmentalization within the digestive system. So things that separate the small bowel from the large bowel. And if we break the small intestine down into its individual components, we've got the duodenum, which is closest to the stomach. It's got an opening that directly leads right into the pancreas. And then it also has a common bile duct that goes up and also is connected to the liver and the gallbladder. And so that's where our digestive enzymes are released into our small intestine, is in the duodenum area, and they're released basically to help neutralize what's coming into the small intestine from the stomach. The jejunum is this expanded region of nutrient absorption. It's often an area that becomes compromised because of small intestinal bacterial overgrowth. And then the ileum is the last part of the small bowel before the small intestine becomes the large intestine. And you probably heard of the ileocecal valve that separates the small bowel from the large bowel. The ileum is also the major seat of immunity within the digestive system. And so there can be many reasons that SIBO develops. For some people, it could occur because of surgery. They've had some kind of intestinal surgery that's disrupted the anatomy. Motility disorders, that can be linked to celiac disease, to small bowel dysmotility secondary to diabetes, for example. Other neurological problems could contribute to it. And then I mentioned metabolic disorders like diabetes is certainly a leading cause too. Hypochlorhydria, so people not producing enough stomach acid, could be a contributing factor to SIBO as well. And then in line with that, many people are on acid blockers, things that reduce stomach acid. Those are actually a leading cause of SIBO development. And then recurrent antibiotic use and other types of chronic digestive problems. So the common things, again, are GI issues secondary to hypochlorhydria, motility type disorders, recurrent use of acid blocking medication, and then anything that's going to disrupt the small bowel with regards to the ileocecal valve. So the ileocecal valve is that valve between the last part of the small intestine, the ileum, and the large intestine. Pathogens can be either a causative or contributing factor to SIBO. So you can get a viral gastroenteritis that can cause inflammation around the ileocecal valve area, and that allows for the ileocecal valve to stay open, and basically that can allow for large intestine bacteria to kind of move backwards into the small bowel. Parasitic infections can trigger that too, like Giardia. And then there's a wide variety of bacterial infections, from Shigella to Campylobacter to Salmonella, that sometimes is a trigger. Certain toxins that are produced by intestinal pathogens will also alter the movement of debris or things that are moving through the small intestine. There are certain gram-negative bacteria called, such as Campylobacter or Shigella, for example, that produce something called cytolethal distending toxin. And these toxins can interfere with a mechanism in the small intestine that's linked to certain cells called the interstitial cells of Cajal. And the interstitial cells of Cajal act as a pacemaker, if you will, for the enteric, what's called the enteric nervous system, these muscle fibers that act basically to help propel debris and foodstuff through the small intestine and sweep it into the large intestine. The migrating motor complex is part of this network called this migrating myoelectric or motor complex network. And basically what we get is waves of electrical activity that move through the intestines, including the small intestine, and that helps to move bacteria and other digestive debris out of the small intestine into the large intestine. And the activity of the migrating motor complex is most active during fasting states. So in between eating and certainly throughout the night or the overnight period when we're asleep. And most of us have anywhere between 8 to 12 migrating motor complex waves activity that occur over a 24-hour period of time. A typical person with SIBO, for example, might only have 3. So things tend to just get stuck in the small intestine. There are a number of digestive system problems that can be linked to SIBO. So if we get what's called bacterial fermentation of carbohydrates, there are various gases that can be produced. So hydrogen gas, methane, or even sulfide gas, that produces that rotten egg smell, can be problematic. And these gases over time can be damaging to the sensitive cells that line the small intestine, particularly within the jejunum, that major absorptive area within the small intestine. Constipation from a SIBO standpoint, as well as an irritable bowel standpoint, is often linked to elevated levels of methane gas. Now, that's not to state that all cases of constipation are from methane, but typically methane elevations can lead to cramping, to bloating, to increase potential for what's called auto-intoxication, because if we can't move toxins out of our bowel, many of those toxins get reabsorbed from the large intestine. Diarrhea or loose stools is often linked to hydrogen excess production, either in a SIBO or an irritable bowel scenario. And then we can have a mixed pattern where we're getting alternating constipation, loose stools, or diarrhea. And this is because a mixed pattern of hydrogen and methane, meaning that both are elevated. Bloating, cramping, pain, flatulence, maldigestion are all common. And if you look at a typical SIBO profile that's measuring hydrogen and methane, as we start to get levels above 20 parts per million of hydrogen and above 10 parts per million in methane, we can then start to see that mixed bowel pattern. So in this particular case, if it was only hydrogen, the person would have more of a tendency towards loose stools, diarrhea. If it was only methane that was high, they would have a higher tendency towards constipation. Now, one of the things to keep in mind about SIBO is, and one of the things that makes it a challenge for patients, is that it has a high recurrence rate. It tends to come back. And there's many factors that can contribute to SIBO development. There's also many factors that can contribute to its recurrence. One of the things that happens as practitioners is oftentimes not enough diagnostic testing is done. So somebody does just a hydrogen and methane test and then tries to just treat SIBO based off that information. And you might get lucky where you're able to, resolve the problem 100% the first go around, but that's typically not the way SIBO progresses. It usually is a recurrent problem. And so we can't just focus on just bacterial levels in the small intestine. We actually need to address SIBO from a very comprehensive standpoint. And the other thing we have to consider is that there are people who have what appears to be SIBO, but when they're tested, the tests are not positive. And so not everything that appears to be SIBO may be SIBO. Okay, so we can't get pigeonholed in thinking that, that every digestive problem is linked to this. So treating SIBO comprehensively, yes, we need to be able to reduce small intestinal bacterial overload, but we really also need to address digestion from a total standpoint, liver gallbladder function, as well as things happening in the large intestine, as well as trying to promote intestinal motility. And so the digestive system is really a functional unit of coordinated physiology. And digestion begins in the mouth. So that's the first place that people need to work. And then also understand what happens in the mouth has a reflex into what happens in the stomach, which then has a reflex into what happens in the small intestine, etc. So chewing food appropriately, supporting stomach digestion, oftentimes with either enzymes or hydrochloric acid, supporting small intestinal motility. And one of the ways that's done is not only addressing function of the pancreas because it produces enzymes to help with digestion, but supporting liver and gallbladder function via producing bile acids and helping the release of bile acids from the liver. In fact, this has been an often overlooked factor in irritable bowel as well as SIBO intervention, is not doing liver support, because bile acids have a stimulating effect on the migrating motor complexes. They help with fat digestion of fat-soluble vitamins. They also have a reflex into what happens in the large intestine. So it has some activity on large intestine motility as well. So if we're not addressing all of these factors, oftentimes we're left with ineffective types of treatments. So one of the things that my partner in practice, as well as partner in the Integrative Medicine Academy, talks about is that, the digestive system has only so many presenting symptoms towards imbalances. And so symptoms that are attributable to SIBO may also be symptoms of other problems. And that's why it's important for us as practitioners to do comprehensive testing. We can't just do hydrogen methane testing. We need to do that, obviously, to diagnose SIBO. But we need to also look at other factors that can affect digestion. One of the things that we do in our practice on everybody who comes to us with a chronic digestive problem, that could be SIBO related, that could be irritable bowel, that could be something else, or people in general who are dealing with chronic health issues, from gut problems to autoimmune to neurological issues to chronic fatigue, is organic acids testing. Now, we put a lot of emphasis on the organic acids test from Great Plains Laboratory. And this is a critical test that we believe every practitioner should have at least a working knowledge of using in their practice. If you have a specialty practice that's all entirely just SIBO, you need to learn how to do the OAT, because there's many markers on this test that are really important for people with SIBO conditions. Now, organic acids are compounds that all of us produce naturally. So lactic acid, for example, is a organic acid that can represent, underlying problems when it's elevated, metabolic acidosis, for example. And then there are organic acids that get produced by organisms that live in our digestive system. Some of them commensal, others are infectious and opportunistic. If you've looked at a typical organic acid test, all of the companies that do these tests have some markers that are reflective of intestinal bacteria, as well as Clostridia bacteria. So the organic acid from Great Plains Lab, for example, we can see a number of markers that are linked to dysbiosis. These markers here, for example, indicate some kind of dysbiotic condition. This isn't defined as SIBO. These could be coming from the large intestine, but this is suggestive of bacterial imbalance in the digestive tract. There's also Clostridia bacteria markers, and this is something that's often overlooked because most people will do a stool analysis for the Clostridia toxins A and B, and then when they're normal, they say, well, the person doesn't have a Clostridia problem, but the organic acid test from Great Plains has many markers of Clostridia bacteria. Some of these things actually affect the nervous system. And these are really important because they can interfere with our treatment of anybody with a chronic digestive problem. And the only way to pick them up is actually to have them analyzed through an OAT test. The most common one that shows up is something called HPA. This is linked to a number of different Clostridia bacteria. 4-hydroxyphenylacetic and 4-creosol, for example, can be linked to C. difficile. It's interesting, there's been some old research that showed that elevations of 4-hydroxyphenylacetic acid have been linked to small bowel disease. Now, just having an elevation of 4-hydroxyphenylacetic doesn't diagnose SIBO. But again, when you have multiple bacterial markers elevated in somebody, there's a greater chance that they have some underlying chronic digestive problem, dysbiosis, whether it's in the large intestine or small intestine. In order to absolutely diagnose SIBO, we'd still need to do the hydrogen and methane breath testing. But again, we need to also identify these things too, because they can be linked to other things happening from a health standpoint, particularly neurological and brain issues. Clostridia in general are problematic, and most of the medical profession focuses on Clostridia difficile in what's called Clostridia difficile infections, and for good reason, because in a serious form, these infections can be lethal. And there's thousands of people who die every year because of C. diff infections. What happens with Clostridia, as they enter the small intestine, they change from a spore form. These spores are very resilient out in the environment, But as we ingest the spores, they transform into what's called a vegetative phase or a vegetative form. And it's in that form that they start producing different types of toxins. So by the time they hit the large intestine, there's usually a wide range of inflammation, toxicity, bowel inflammation, leaky gut, etc. What's also known about some of these organic acids that's picked up on an organic acid test, like creosol, which comes from C. diff, or HPHPA, is these can interfere with dopamine metabolism. And dopamine is normally converted into norepinephrine to support nervous system function as well as energy production in the body, particularly as it gets down to the level of epinephrine. But in the presence of these toxins, we inhibit dopamine beta hydroxylase. As dopamine beta hydroxylase is inhibited, we get an increase of neurological dopamine. That can cause an increase of homovinylic acid to be seen on the OAT test. But the problem is too much dopamine in the nervous system is toxic. It leads to apoptosis of nervous system cells, as well as leads to glutathione deficiency and neurological degeneration. And these are systemic effects, okay? This is not something that's just specifically in one nerve cell type. The only way to actually detect the presence of these organisms is through organic acids testing. And this is something that we put a tremendous amount of emphasis on and feel very strongly, again, that every single person who either has a diagnosis of SIBO or it's suspected should have an OAT test done. One of the other aspects of OAT testing, or the organic acid testing, is evaluating for fungal problems. I mean, it's long been thought that most people with SIBO are going to have some underlying problem with candida. Well, there are markers on the organic acid test that indicate invasive candida, particularly this marker here called arabinose. When arabinose is high, it's indicating that candida is becoming invasive in the digestive tract. And invasive candida can actually lead to leaky gut, for example. But there are other markers, 2, 4, 5, and 6, which are strongly associated with Aspergillus mold. And whenever you see an elevation of one of these markers on the organic acid test, you're looking at an individual who has some colonization of Aspergillus in the gut. A negative test, meaning you do an organic acid test and these Aspergillus markers are normal, doesn't mean that the patient couldn't have been exposed to Aspergillus. They still could have exposure. It's just manifesting in a different way, which I'll talk about here shortly. But in this particular person, we can see we've got very high levels of these Aspergillus markers. So they have an overgrowth of Aspergillus mold in the gut. There's another chemical on the oat called tricarboxylic. Tricarboxylic manifests as an organic acid when a specific mycotoxin called fumonisin is moving through the digestive tract. Fumonisin is actually produced by Fusarium mold. So the organic acid test on page 1 gives us some representation of Fusarium mold exposure and Aspergillus exposure, as well as candida or invasive candida. Mold is something that all of us can be exposed to, particularly Aspergillus mold. It's the most common environmental mold that people are exposed to. We've seen mold, people being exposed to high amounts in their home, in their offices. I've seen it elevated in kids because of their school. It is a mold that can come about through food as well. Common indoor molds are Cladosporium, Penicillium, Alternaria, Aspergillus, and in their classic sense, they can trigger allergic reactions where the mold spore gets into the lungs and causes inflammation, coughing, for example. They can also cause sinus issues. But all of these molds also produce toxins. And the mycotoxin is different than from the mold. It came from the mold, but you can have scenarios where people are harboring the mycotoxins, but the mold itself no longer exists. And so Great Plains has something called the GPL mycotox profile. And in our various courses that we teach a lot about interpretation of the organic acid test, as well as interpreting the mycotox profile. And this is one of these things that, again, we feel very strongly that anybody with a SIBO diagnosis or irritable bowel diagnosis should have a mycotoxin profile done, because we know that these chronic digestive issues have a high recurrence rate. They're difficult to get under control. These mycotoxins can be immune suppressive, so they can reduce white blood cells, they can decrease macrophage activity, they can inhibit natural killer cells, which are important in controlling cancer cells, for example, or cells infected by viruses. These mycotoxins can suppress secretory IgA. The lower secretory IgA we have in the gut, the greater chance there is for opportunistic pathogens from taking hold. Many of these mycotoxins can generate oxidative stress and deplete glutathione. And some actually target mitochondria, so they're actually known to contribute to mitochondrial damage. The Great Plains mycotox profile at this point analyzes 11 different mycotoxins. Ochratoxin, gliotoxin, and mycophenolic acid are going to be three that I highlight here. Ochratoxin is the most common mycotoxin that all of us are potentially exposed to. You can get it in mold-contaminated coffee, for example. Various grain products can have mold that has the mycotoxin. It's interesting, one of the things that's just been revealed in autism is that many autistic kids carry high levels of ochratoxin, and ochratoxin is a neurotransmitter inhibitor. It actually can inhibit certain neurotransmitters linked to tyrosine and phenylalanine, for example. Ochratoxin is also nephrotoxic. It's also carcinogenic. It is linked to Aspergillus. And in fact, this particular slide you're seeing comes from somebody who has high levels of Aspergillus exposed in their home. It got organic acids elevated on their OAT test, reflective of gut colonization of Aspergillus, and they have a very high ochratoxin A level. Mycophenolic is another common mycotoxin seen on the mycotox profile. It too is a major inhibitor of the immune system, both T and B cells. B cells are what produce our antibodies, including IgA, which would become secretory IgA. And what's often seen is when mycophenolic levels are high is we often see an increasing amount of Clostridia toxins as well as Candida toxins. In fact, the studies have actually shown that mycophenolic secondary to Penicillium mold is immune suppressive and can lead to an overexpression of Clostridia and Candida problems in the gut. Gliotoxins are another toxin produced by Aspergillus mold. You can see in this particular case, the level is extremely high. This is the highest personally I've ever seen. And one of the problems with gliotoxin, as I mentioned before, these things can deplete glutathione. Well, gliotoxin is a major damager of mitochondria. And one of the things you have to think about with regards to SIBO and chronic digestive issues is that mitochondrial dysfunction can also affect the function of the gut. So if we have things that are inhibiting mitochondrial activity, sometimes our patients can be more than just fatigued. They can have, fatigue that might be manifesting at multiple levels throughout the body, including the brain and nervous system, including the gut and digestive function as well. And so one of the things that's common on the organic acids test when these mycotoxins are high, particularly gliotoxin, is you'll see a fair amount of elevated Krebs cycle and mitochondrial metabolites being elevated, which means that the biochemistry related to mitochondrial activity is severely compromised. Lactic acid, interestingly enough, on the oat test linked to lactic acidosis, has a strong association with mycotoxins. And so one of the things that we look at on the oat test is not only these other mitochondrial markers, but also, do we have an elevation of lactic? Common issues linked to lactic would also be glucose dysregulation, so not being able to metabolize glucose effectively. But that has a strong association with gliotoxin, or just mycotoxins in general. And why this is important and why we believe it's really important is that mycotoxins, and some of these mycotoxins are actually will interfere with normal function of the migrating motor complex. In fact, this mycotoxin called deoxynivalenol is produced by Fusarium mold. I had mentioned before on the oat test that tricarboxylic organic acid on page 1 of the oat is reflective of Fusarium exposure. Fusarium is a mold that's common in the environment, can be present because of mold damage, but can also be present in corn and corn products and other grain products. So it's a common mold contaminant of food. And Fusarium is actually known to produce a lot of different mycotoxins, things that fall into a group called trichothecenes. And these trichothecenes are toxic at many levels. There's other types of Fusarium mold mycotoxins, but this one particular one, interferes with our migrating motor complex, and that has a link back potentially for SIBO. Now, this particular one, deoxynivalenol, is not measured on the mycotox profile from Great Plains, but there are other mycotoxins on the Great Plains mycotox profile that can be linked to Fusarium mold. So when it comes to SIBO testing, there are other types of labs that should be done. Okay, we do an organic acid test on everybody. There's nobody that gets out of my practice that is not doing an oat. Minimally, an oat test needs to be done as an entry level into other assessment. Mycotox profile is also one that I strongly demand that people get as well. We also understand, again, that SIBO doesn't occur on its own, right? It's something that manifests because of something else. So that could be other infections, other digestive factors, food sensitivity, for example. Helicobacter pylori can be a trigger for SIBO in some people. So it's looking at things from a comprehensive standpoint. That's how you make inroads, in our experience, into this condition. Now, we actually have a very comprehensive online SIBO mastery course. It's starting actually next week, the new version of this course. It's 9 modules, It's a 9-module online course. The first 5 modules are heavily dedicated to the SIBO discussion, from diagnosis to pathophysiology to testing to supplement to treatments, both botanical plus medication, and then all of the different diets that are related and necessary in some cases for SIBO. But as I mentioned before, not everybody who thinks they have SIBO has it. And so we have to understand that there are other chronic digestive problems that can mimic SIBO, or at least contribute to it. And that's where we also get into this course, looking at parasites, H. pylori, mold, Clostridia bacteria, organic acid testing, etc. So for more information about the SIBO Mastery course, you can go to sibomasterycourse.com. You can also email to sibomasterycourse@gmail.com. So that course starts Tuesday, July 21st. So here's the outline. So again, we start with the clinical issues, the comorbid conditions linked to SIBO, diagnostic testing, pathogenicity, comprehensive antimicrobial treatments, dietary interventions, and then we get into things like chronic yeast, mold toxicity, chronic infections, Clostridia, etc. So in total, it's a 9-module course, very, very comprehensive. So for additional information about Integrative Medicine Academy and some of our other courses, you can actually go to integrativemedicineacademy.com. We do have online courses for autism, for toxicity issues, for organic acid test interpretation at an advanced level, functional medicine course, etc. So integrativemedicineacademy.com. Any questions you have, please reach out to us at integrativemedicineacademy@gmail.com. Okay, everybody, thanks so much for your attention today on this topic. I'm Dr. Kurt Woeller for Integrative Medicine Academy. Thank you.